All right. Well, thank you for inviting me to come out to this conference. I'm really excited to talk to you about cardiology and on prevention. More specifically, I'm going to talk a little bit about focused on cardiovascular risk. So I do not have any disclosures except that I am a general cardiologist. I do love this field, and I'm really excited to talk to you about it. So this, in 2019, there was the primary prevention guidelines that were produced from the HAACC committees, and it can be summarized in this slide here on the ABCs of primary cardiovascular prevention. This includes first assessment of cardiovascular risk, managing blood pressure, managing a patient's cholesterol, managing their cigarettes or smoking, helping them to quit, helping them to work on diet and obesity, helping them to work on their diabetes, and then, of course, importantly, helping them to exercise and get that 150 minutes of cardiovascular aerobic exercise daily. So all of these, I think, are exceptionally important, and if we were to talk about, or if I were to talk about all of these in a single presentation, I think I'd have to talk at 1,000,000 miles an hour. Therefore, I've decided to focus my presentation on these following objectives. First and foremost, I want to talk about the current methods to help us understand a patient's individual risk, and then discuss about the utility of or understand the indications for cholesterol-lowering medications, particularly a focus on statins. Following, talk about the utility of risk-enhancing factors that we can use to adjust a patient's risk away from the pooled cohort equations that we commonly use. And then finally, talk about several patient populations that we see in our clinical practice on a day-to-day basis. First, I'd like to go back in time. Prior to the 1960s, we really did not have a great understanding of what we consider traditional risk factors and the increased risk that they have in atherosclerotic events. In 1948, there was the Framingham Heart Study, which came out, started to evaluate these patients. They were from a cohort of about 5,000 patients from Framingham, Massachusetts, and they followed them for about 20 years. And what they found is that conditions such as hypertension, diabetes, smoking, sedentary lifestyle significantly increased the risk of these patients developing cardiovascular disease. Fast forward a couple of decades, but several decades ago, the Framingham Heart Score was developed and subsequently had an update in about 2008 to help us better understand and assess these patients' risk with risk tools. However, the Framingham Heart Score was relatively, the population was not very diverse, coming from one city in Massachusetts. Further, they really focused mostly on coronary heart disease and not all atherosclerotic events. Therefore, in 2013, the HA and the ACC published a new pooled cohort equation that involved 5 different cohorts. These were a little bit more racially and ethnically diverse, containing patients from various locations throughout the United States that were African American and white, and came up with this algorithm here. This is the one that, or this score here, this is one that predominantly I use in my clinic, although not the only one that we have available to us. There are actually many risk assessment scores out there. Just to name a couple here, in 2023, the PREVENT score was published. This included actually 46 different cohorts, 6 million individuals, and from a variety of locations with multiple different racial and ethnic backgrounds. This evaluated key traditional factors, including the ones we usually have, but also other key cardiovascular, kidney, and metabolic conditions such as these shown here. It also assessed both a 10-year, but also lifetime risk, 30-year risk. And then on top of that, it gives us not just atherosclerotic event risk, but all cardiovascular disease, including the risk of developing heart failure. On the other hand, here on the right, we usually will use a tool to help us understand risk enhancing, which is the calcium score. In 2015, the MESA cohort developed a risk tool that included, in addition to traditional factors, the calcium score. Therefore, with these, we can actually start working on tailoring our risk to our individual patient, and instead of just rather using one single pooled cohort equation. So the next question is, why discuss risk assessment? And more specifically, how do we tailor these to our patients? Cholesterol management, except for in the patients with elevated LDL of greater than 190 milligrams per deciliter, is based on patient's risk. In this diagram from the AHA-ACC guidelines in 2018, it is heavily dependent on when and if we should start a statin based on the patient's risk. Starting in the top right, we can see that those, even with diabetes, we should be calculating their risk to determine if we should start them on high or moderate intensity statins. Further, if in patients that are aged 40 to 75 with an LDL of 70 to 189, that we stratify them based on either whether they're low, borderline to intermediate, or high risk. And then with that, whether we should start statin and on what dose we should. I'll review several points within this diagram throughout the rest of this presentation today. So I think the first step in the management of statins is to first understand dosing. And in general, we usually will be prescribing either moderate intensity or high intensity statin dosing. Ones that I predominantly prescribe, and I see most of the ones in my cardiology group, is either atorvastatin or rosuvastatin. It's very nice. They can start out at moderate intensity statins and subsequently increase to high intensity statins if their cholesterol levels do not decrease to the appropriate amount of either 30% in moderate intensity or 50% in high intensity groups. Further, the use of low intensity statins. In general, unless there's patients that have significant side effects, have relatively minimal use that I can see in this patient population. So it's quite, I think, clear on what we need to do in patients that are in low risk, really focusing on lifestyle management. It is also quite clear on what we do in patients that are high risk. We should be emphasizing all aspects of their atherosclerotic risk and starting them on higher intensity statins. However, it's more difficult to determine what we should do those that are in the borderline to intermediate risk. Based on the AHA's ACC guidelines here, really we should be looking at risk-enhancing factors to tailor to our individual patient. As I mentioned, this is always about tailoring to our individual patient. And there are many risk-enhancing factors that we can use to decrease their risk, and many of them can just be at the bedside in the clinic room without additional studies. That could include things like, do they have a history of family history of premature atherosclerotic disease? Do they have a very elevated LDL of greater than 160? Do they have metabolic syndrome? Do they have chronic kidney disease? Do they have chronic inflammatory conditions? In women, do they have a history of premature menopause? Or do they have significant pregnancy complications such as preeclampsia? And then are they of a high race or ethnicity such as South Asian ancestries? And then finally, if the risk is still uncertain in this patient population, then there are other tests that can be performed in order to help us really understand that risk. There are numerous out there, and I'm going to talk about a couple of these now. So the first is Lp(a). What is actually Lp(a)? This is an LDL variant. It contains a protein called ApoB. This ApoB has a similar structure to that of plasminogen and may inhibit fibrinolysis, and in vulnerable plaques increase that risk of atherosclerotic events. In the National Lipid Association guidelines, they suggest that concentrations of Lp(a) greater than 50 milligrams per deciliter, or really preferentially in nanomoles per liter of 100 to 125, confer high-risk patients. However, I think more recently they've been looking at this and finding that there's more of a causal relationship. As you can see in this study on the right, involving thousands of patients, that they found that as the Lp(a) increases, so does the patient's risk. Therefore, the risk can be additive to that of like say a pooled cohort equation, or their overarching or underlying risk. Also of note, and also very helpful in helping us determine which patients we should really be looking at getting an Lp(a) on, is that Lp(a) concentrations are predominantly genetically determined in up to almost 80 to 90% of patients. Therefore, initially, the National Lipid Association guidelines suggested that in those patients greater than 20 years of age who have a family history of premature atherosclerotic disease, it is very reasonable to get an Lp(a). Further, those that have very high levels of cholesterol, such as an LDL of greater than 190, in which it may be considered an inheritable disease, also getting Lp(a)s on these patients. The next risk-enhancing factor to discuss is high-sensitivity CRP. Over the last several decades, I think we've come to understand that atherosclerosis progression is not just dependent on cholesterol levels, but also dependent on inflammation. For example, we know that earliest manifestations of atherosclerosis, there are, in histological examples, inflammatory cell accumulation such as lipid-laden macrophages within the vessel wall. We also know that autoimmune conditions, as mentioned earlier, increase that risk of atherosclerotic events. CRP is a marker of inflammation and has been studied extensively, demonstrating that elevated levels of CRP increase the risk of vascular deaths. In this study here, it demonstrated that there was a 1.8-fold increase in patients with a CRP level of 3 times that of normal for all vascular deaths. So in the ACC guidelines, they suggest that individuals with a high sensitivity CRP, that is just a more sensitive assay than the original CRP, of greater than 2.0 milligrams per deciliter, suggest a higher risk individual. Patients that I start considering thinking about this, those that maybe have subclinical concern for inflammation, those that are smokers, those that are morbidly obese, those that have very sedentary lifestyles, those that have very poor dietary habits, including those high in saturated fats. The next risk enhancer, and this is probably the one that at least I use most frequently, is the coronary artery calcium score. This is just a simple non-contrast CT scan that quantifies the amount of calcified plaque surrounding the coronary arteries. Not only does the presence of calcified plaque, but also the burden of the burden of plaque help determine the patient's individual risk. This study here, which came out in 2008, so quite a while ago, enrolled individuals who were aged 45 to 85 that had no prior history of atherosclerotic events, and it really demonstrated the power of the coronary artery calcium score, showing that it is a strong predictor of heart disease. In patients that had even a score of 1 to 100, had a 4-fold increased risk of atherosclerotic events than those with a calcium score of 0. If the score was greater than 100, they had upwards of a 7-fold increased risk of atherosclerotic events. So the AHA-ACC guidelines suggest that it's reasonable to obtain a coronary artery calcium score on patients who are in that borderline to intermediate risk, 40 to 75, with an LDL of 70 to 190. That helps us really assess those patients. The question, though, that comes up is now which of these risk-enhancing factors should we be reaching for? And as I mentioned earlier, I'm a little bit more prone to reaching for the calcium score. This study, which actually is a risk comparison study, it involved both coronary artery calcium score and CRP with a lot of other traditional risk factors, enhancing factors. While all of them, in comparison to the Framingham Heart Score, did increase the patient's risk assessment, but calcium score had a far better risk reclassification than those other risk markers. The calcium score here is the line in black. That's the most sensitive and the most specific. Therefore, it's really my initial choice, particularly in patients who are older really greater than 40 years of age to get these. Sometimes those that are younger, in their 20s and 30s, they haven't had the time to develop the calcified plaque. And I might be reaching in those patients for some of these other risk-enhancing tools or risk-enhancing studies. So now that we've kind of gone through this, we've got the calcium score, I think the guidelines really suggest that anyone with a score of greater than 0 should be started on a statin. And it should be on higher intensity for those with higher calcium scores, particularly if that score is greater than 300 at Gadsden units. Further, those with a calcium score of 0, which is a very interesting population, who were previously categorized as high risk, such as borderline to intermediate, which is in that 5 to 20%, can be reclassified as low risk. This patient population has a 1 to 2% chance of atherosclerotic events over the next decade, significantly or well within that low risk category. This recommendation, I think, partly came from this quite large study. It involved 14,000 patients that was a cohort study that had calcium scores and then followed them for about a decade. On the top left here is patients with a calcium score of 0. And they looked at patients who were on a statin versus not on a statin. And there is absolutely no difference over the course of a decade in those who are on a statin or not on a statin. But then, as the calcium score subsequently increases, calcium score 1 to 100 in the top right, 100 to 400, bottom left, and then greater than 400, we can see the subsequent benefits of statin therapy in these patients. So going away from the calcium score and onto different patient population, and the next is patients with an elevated LDL of greater than 190. These patients really do have a significant increased risk of premature atherosclerotic disease, and there's really concern for heterozygous familial hypercholesterolemia in this group. This study that I've demonstrated here really sought to understand that risk of LDL, particularly in those that were in younger age. And what they found is that patients with an LDL of greater than 190, compared to those with an LDL of less than 130, had about a 5-fold risk of atherosclerotic events over their lifetime. Or really, they were looking at 30 years. There we go. So now that the next question is, well, if we get these patients on a statin, does it really help them? And it really does decrease their risk. This was a study in patients with familial hypercholesterolemia who had significantly higher cumulative event-free survival compared to those that did not get started on a statin. They also demonstrated, which I think is very important, that the outcomes of patients who did get started on a statin was really similar to that of the general population. Therefore, the guidelines suggest that anyone with an LDL greater than 190 really do need to be started on maximally tolerated statin therapy. So not just the rosuvastatin at 10, but really trying to push them up to rosuvastatin 40 to continually decrease that risk. So another group that I think can be challenging is those that are 20 to 39 that have an elevated cholesterol level, but it's really not all that, it's 160 to 190 milligrams per deciliter. I think the first step is really recognizing that this patient population still has a quite elevated risk. This study here was actually, I think, quite interesting. It tracked patients 18 to 30, and they tracked their LDL, and then they took their average LDL and multiplied it by their age to get an LDL AUC risk score. Once the patients reached 40, they then stratified them into each quartile. And they subsequently found that as they followed these patients over the next 16 years, that there was a significantly increased risk in each quartile in these patients when looking at them when they were in their younger years. While I feel like these can be difficult to manage, I think there's several things that we can do to really help them. The first is focusing on explaining what their lifetime risk is of having an atherosclerotic event, and then helping them focus on significant lifestyle changes. Next is really looking to make sure they don't have any other secondary secondary causes of hypercholesterolemia. And there can be several: alcohol intake, diabetes, significant liver disease, albuminuria. And then finally, if they do have other risk factors such as family history of premature atherosclerotic events, we do suggest starting a cholesterol-lowering medications in this patient population. And last but not least, I think once we get patients on a statin, I think every single one of us has probably experienced this, is that the patient comes back and saying they have horrible muscle aches. So statin-associated muscle symptoms is actually quite common. In observational studies, we see that it's anywhere from 5 to 25% of patients. However, if you look at trial data, we see that only 1 to 2% are considered what we say pharmacologic statin-associated muscle symptoms. This is basically stating that the medication is the cause. This very large meta-analysis that I'm showing here on the right involved 19 different trials of patients who were randomized either to placebo or statins. And what they found is that really only 1 in 15 of the patients who developed symptoms was because of the medication. So the question is, though, we still have the patient in front of us complaining of these muscle aches. How do we really help them? The first step from the National Lipid Association guidelines suggests acknowledge the symptoms. We can't just blow them off. We have to continue to build that rapport with the patient and really assess the risk. Does it seem very severe? Is it really affecting the patient's quality of life? And if so, then we need to probably back off on the statin, maybe decrease the dose and or stop the medication. I do suggest retrialing another statin, usually at a lower dose. And there is significant data out there to suggest that most patients who retrial statins later on tolerate the medication. And then if after several tries with these different classes or different medications, I do suggest jumping over to non-statin medications, then also helping them focus on other risk reduction, diabetes, hypertension, smoking. So in summary, in primary prevention is really a lifelong endeavor with our patients. While utilizing pooled cohort equations, all patients should have their risk for cardiovascular disease individually reviewed. There are numerous risk-enhancing factors that we can use at our disposal to either increase or decrease our patient's risk. And then remember that statin therapy initiated based on risk at appropriate intensities is critical to their risk reduction. And then finally, please retrial the statins if they develop muscle aches and go up slowly. Thanks for your time.
We're going to have. Okay, we'll have a few questions, and I think Mark Johnson outran Mike Matthews, so you're first.
So with all the evidence you presented with calcium score, when do you think that will make it into the recommendations from the U.S. Preventative Task Force, and when do you think insurances will cover that as a preventative benefit?
That is a great question. I'm honestly not 100% sure when it'll reach into the U.S. Preventative Task Force. I'm hoping soon. I'm hoping that insurances will start covering it. The nice part about these the calcium score is in most places it's not very expensive. It's looking at anywhere from $50 to $150 per calcium score. And at least for me, I find when I'm talking to patients, it's absolutely beneficial. I do hope soon that it's starting to be more covered by insurance because I keep having to have patients pay out of pocket for it.
Mike?
Yeah, that was one of my questions. The second, I've got two other questions. The first one is I've heard some people, talk about when they're getting Lp(a), getting concentration versus particle count. How important is that? Is that an important distinction to make? That's the first question. And the second question I have is, in patients who are statin intolerant, who have familial hyperlipidemia, how are we using PCSK9 inhibitors yet for primary prevention?
Okay, that's great. So for your first question, if you look at the National Lipid Association guidelines, they do suggest that we use particle count, which is in nanomoles per liter, and they're really wanting us to standardize probably universally in nanomoles per liter. They feel like that's a little bit better measurement, partly because I believe it has a little bit, LP little a is very heterogeneous in its size, and then therefore can have varying concentrations, particularly if we're using milligrams per deciliter. And so I am hoping in the future that we'll all be transitioning over to nanomoles per deciliter rather than milligrams, or nanomoles per liter instead of milligrams per deciliter. And then as far as familial hypercholesterolemia, I am getting patients on PCSK9 inhibitors that I see in my clinic, particularly if they are statin intolerant. I think it just has to be pretty well documented in these patients that they are statin intolerant, trialed a few different types of statin medications, and then I've been finding that my patients, I am getting on PCSK9 inhibitors that have this very elevated LDLs, and meeting criteria for familial hypercholesterolemia.
Okay, last two.
My
Go
question
on,
also
go
has to
ahead,
do with
Chris.
the coronary calcium score. So those patients that are a score of 0 or maybe 1 to 100, is there a recommended interval follow-up? Should we repeat it a few years later?
That's great. So we know that calcified plaque is a very slow and slowly to progress. In a patient with a calcium score of 0, in general, we can say that it's probably going to be remaining 0. There's I believe a 20 to 25% chance over about 7 years of it changing. So if you look at the National Lipid Association guidelines, they produced a recommendation stating that you can repeat in a patient at 0 about 5 to 7 years later and have no significant concern about them increasing drastically. Only 20 to 25% of those patients will have a change. In patients with a score of 1 to 100, they're a little bit more aggressive. They suggest maybe anywhere from 3 to 5 years in repeating that calcium score. And I think that's just to help us tailor the therapy if they are someone that's going to be jumping into that higher risk group, the ones that are greater than 400, to help push that higher intensity statin.
Okay. Thank you, Dr. McCandless.